Welcome back to OMFS Essentials, concise knowledge for the modern maxillofacial surgeon. Today we'll cover the surgical needle, core suture principles, and knot tying, the foundation of atraumatic wound closure. 1. Ideal surgical needle. What good looks like. An ideal needle is high-grade stainless steel, sterile, and corrosion-resistant. The smallest possible diameter that still carries the suture, stable in the needle holder, no wobble while driving, able to pass with minimal trauma, with a sharp tip and low friction body. 2. Needle performance terms, quick definitions. Strength. Resists permanent bending on repeated passes, more strength, less tissue trauma per pass. Ductility. Can bend without breaking, important if you must gently reshape a needle. Sharpness. How easily the tip penetrates tissue. Clamping movement. How securely the needle sits in the holder's jaws. 3. Needle anatomy. Point. From the tip to the needle's maximum cross-section, it dictates penetration and tissue cut. Body. The main arc that the holder grasps, transmits force to the point. Swage. The suture attachment end creates a continuous needle suture unit. Types: channel swage, drill swage, and non-swaged, eyed needles. Coating: silicone or similar to reduce initial penetration force and friction through tissue. 4. Needle curvature and when to use what. Select curvature for access and maneuverability. Straight or slight curve, superficial skin, and easily accessible surfaces. Half circle, general intraoral work, balanced reach and control. 3/8 circle, common for finer work with moderate depth. 5/8 circle, confined spaces, e.g., palatal mucosa. J curvature, helpful at depth or difficult angles. Choose needle size according to tissue toughness and working space. Tighter spaces and tougher tissues often benefit from a smaller, tighter curved needle. 5. Needle measurements. What package numbers mean. Cord length. Linear distance from tip to swage, approximately bite width. Needle length. Distance along the curve from tip to swage. This is what boxes list. Radius. Distance from the needle's body to the circle's center. Relates to bite depth. Diameter. Wire gauge. Thicker wire is stronger but more traumatic. 6. Core suture placement principles. Atraumatic technique. Grip point. Hold the needle about 3/4 from the tip. Entry angle. Perpendicular to the tissue surface. Oblique entry tears. Follow the curve. Drive with wrist motion that matches the arc. Don't push straight. Symmetry. Equal distance from the incision and equal depth on both sides. Direction rules. From free to fixed tissue, from thinner to thicker tissue, from deeper to superficial. Eversion. Take a longer intra-tissue path than your edge distance to achieve slight eversion and anticipate scar contraction. No strangulation. Approximate. Don't blanch. Undermine if needed to relieve tension. Knot off the line. Don't sit knots directly over the incision. Spacing. Approximately 3 to 4 millimeters between sutures. Place closer where there's significant underlying muscle activity, for example, tongue. Correct dog ear. Undermine. Make about a 30-degree auxiliary incision toward the parent line. Advance and trim excess. Then close in standard fashion. Avoid dead space. Oversized, tightly cinched sutures create cavities and epithelial tracts. 7. Choosing suture size and reinforcement. Use the finest size that matches native tissue strength. If postoperative strain is expected, add temporary retention sutures. Remove once the patient stabilizes. 8. Knot tying. Principles that prevent failures. Small, secure, simple. The simplest knot that won't slip is best. Cut ends short to reduce foreign body load. No sawing. Don't drag one strand over another under tension. This weakens fibers. Opposed traction. Pull ends opposite, steady, even, fewer breaks, better seating. No instrument damage. Never clamp segments that will remain in situ. Avoid crushing with forceps. Anticipate edema. Tie just tight enough for approximation. Edema will increase tension. Control after first throw. Maintain traction to prevent loosening while you set the next throw. Extra throws not equal extra strength if the knot is already properly formed. They only add bulk. 9. Standard knot types. When to use which. Square knot. Alternating throws in opposite directions. Workhorse for most materials. Gut or collagen, silk, including virgin silk, cotton, stainless steel, uncoated synthetics, polyester, polyglactin 910. Place first throw concisely, secure with a double loop if needed, then square the second throw. Add throws if under tension. Surgeon's knot. Double first throw, then single opposite throw. Reduces slippage while you set the second throw, useful with slippery monofilaments. Granny knot. Same direction first two throws. Third throw squares it, generally less secure. Avoid as a final knot when high security is needed. Material notes. Monofilaments, nylon, propylene, PDS, and monocryl are slick. Plan additional throws and consider a surgeon's knot to reduce early slip. Braided materials seat more easily, but can bulk up. Use the minimal, secure number of throws. 10. Needle holder. Habits of control. Match holder size to needle and anatomic site. Grasp at 3/4 from the tip. Keep the point facing your thumb. Check jaw alignment. Tips should meet first. Lock on the first or second ratchet only. Overlocking crushes. Use a tripod grip for stability and precision. Treat needle plus holder as one unit. No levering or twisting against tissue. 11. Final pearls on closure and healing. Wound outcome is shaped by the needle's entry trauma, the suture's friction and coating, and the material's behavior in tissue. Choose the smallest capable needle, drive it on its curve, use the least traumatic suture that achieves secure approximation, and tie a compact, reliable knot off the line. That's your concise guide to surgical needles, suture principles, and knot security. The everyday skills that determine whether wounds heal quietly or complain. You're listening to OMFS Essentials. Subscribe for more high-yield episodes. And as always, keep mastering the essentials.